All right, tonight we are stepping right into the middle of the controlled chaos of an emergency room. We're going to follow a case that, well, it's one every doctor dreads, a severe traumatic brain injury. This is a story about physiology, incredible pressure, and a desperate race against the clock.
So picture this. The ambulance doors fly open, and a 75-year-old man is wheeled in. The paramedics are moving with purpose, and the initial report they give is short, but it's incredibly alarming.
Right away, this wasn't just a simple slip on the ice. The story is that there was an assault. He was pushed, he fell, and he hit his head hard against a wall. That mechanism of injury, it's direct, it's violent, and it has everyone on high alert.
And by the time he hits that bed, he's already getting worse. He's groggy, barely responding, and then he starts vomiting. That is a classic, really ominous sign in head injuries. For the trauma team, you can just feel it. The clock is officially ticking.
Okay, let's break this down. In those first few seconds, this incredible, almost choreographed assessment begins. This isn't guesswork. It is a systematic hunt for whatever is going to kill this patient first. And immediately, two things from his profile just jump off the page and set off all the alarm bells. First, he's 75. At that age, the brain naturally shrinks a little bit, which stretches out the tiny veins around it, making them way more vulnerable to tearing. And second, he's on blood thinners. That's a huge problem. It means if he's bleeding anywhere, his body's going to have a much harder time stopping it.
In any trauma situation, the primary survey is absolutely everything. It's this super fast, hands-on evaluation to find and immediately fix anything that's life-threatening. And it's all guided by a simple little acronym, ABCD.
So you've got A for airway, B for breathing, C for circulation. And in our patient's case, his airway is clear, he's breathing on his own, and his blood pressure is holding steady, for now. So what does that mean? It means the team's focus just rockets straight to D for disability, figuring out what is happening to his brain.
So how do you measure disability? The first tool you pull out is the Glasgow Coma Scale, or GCS. It's basically a quick score, 3 to 15, based on how the patient opens their eyes, talks, and moves. 15 is a perfect score, 3 is as bad as it gets.
And our patient's GCS? It's an 8. And that one number changes everything. In emergency medicine, a GCS of 8 is this massive red line. It tells you the brain injury is severe. But more importantly, it means he can't protect his own airway from, say, vomiting. The decision is made in an instant. He needs a breathing tube, now.
The next clue comes from his eyes. You shine a light, and you see his pupils are 2 different sizes. This is called anisocoria. The left one is bigger, and it's slow, sluggish to react to the light. This is a huge red flag. It's a physical sign that something inside his skull is pushing on the nerves, and it points right to a problem on the left side of his brain.
So let's recap. The GCS is dangerously low. The pupils are practically screaming that there's pressure building up. All the external clues are pointing to a catastrophe. But to really know what's going on, you've got to look inside.
And for that, there's really only one tool for the job, the CT scanner. This is the absolute gold standard. It's going to give the doctors a fast, incredibly detailed look inside his head and show them exactly what they're up against.
And the pictures come back, and they are stark. The diagnosis is an acute subdural hemorrhage. It's a big bleed on the surface of his brain, about 8 millimeters thick. And worse, it's causing a 6 millimeter midline shift. And that is really bad news.
So what exactly is a subdural hemorrhage? Well, when you get a jolt to the head, your brain can kind of slosh around inside your skull. When it does that, it can tear these super delicate little veins called bridging veins. Once they tear, blood starts to pour out and pool right on top of the brain.
Now, to understand why this is so dangerous, you have to remember one simple, terrifying fact. The skull is a pressure cooker. It's a solid box of bone. There is 0 extra room in there. So when blood starts to fill that space, the pressure inside, the intracranial pressure, just starts to skyrocket.
And that pressure has to go somewhere. A midline shift means the pressure from that bleed is so intense that it's literally shoving the entire brain over to the other side of the skull. That 6 millimeter number isn't just a measurement. It's a direct indicator of just how badly his brain is being crushed. Okay, so with that diagnosis, the team immediately pivots from figuring out what's wrong to figuring out what to do about it. The goal now is to stabilize him and do everything humanly possible to protect his brain from any more damage.
And this right here shows you the incredible balancing act that is TBI care. You have to keep the blood pressure just right, high enough to force blood into that squeezed brain.
You have to pour in oxygen. You have to meticulously manage CO2 levels. And all of it, every single intervention, is aimed at trying to bring down that lethal intracranial pressure.
Now, to really get what this fight is all about, you need to understand a really fundamental idea in brain injury. It isn't just one event, it's two.
You have the primary injury. That's the hit itself, the torn veins, the initial bleed. Once that happens, it's done. You can't undo it. The real fight, the battle that every doctor in that hospital is waging, is against the secondary injury. This is the devastating chain reaction of swelling, inflammation, and starvation from low oxygen or low blood pressure that comes after the hit. And that's secondary damage. That's the thing that's preventable. It's the target of all that care.
And honestly, this just says it all. This is the entire philosophy of trauma care in a nutshell. The first hit is in the past. The whole focus now is on damage control, on fighting that devastating aftermath to give the brain the best possible shot at survival.
And that really is the core challenge of this whole case, isn't it? It's a question that doctors and nurses grapple with every single day. How do you save this incredibly delicate organ while it's trapped inside a box of bone, literally fighting for its life? It's a high-stakes battle to save not just a life, but the very person inside.